Hi, I'm Jocelyn, and this presentation is an extension of a manuscript prepared for NURS611, the final course in the Athabasca MN program. Over the next few minutes, I'll share how the Baby Friendly Initiative, or BFI, can serve as a practical tool for advancing equity goals in Canadian hospitals. While BFI is often seen as a maternal-child initiative, I want to make the case that it's also a powerful systems-level strategy that belongs on the agenda of every nurse leader working towards health equity. We'll start by recognizing how breastfeeding outcomes and health equity are connected. I'll outline how BFI can support both breastfeeding success and equity goals, and we'll consider how implementing BFI can help operationalize equity, diversity, and inclusion strategies already in motion. The intended audience for this presentation is leadership teams in Canadian hospitals, including mat-child clinical leaders who are likely already aware of BFI, like maternity unit managers and educators, and also nurse leaders seeking practical tools to meet EDI objectives, those who may be in corporate roles and don't work in maternal-child health specifically, but are in a position to connect BFI to health equity strategy. I speak from my experience as a nurse educator and BFI project leader at Bright Shores Health System, a multi-site hospital that serves a large and mostly rural geographic area in southwestern Ontario. We are the only fully designated BFI hospital in Ontario. Two birds, one stone. The BFI can address two challenges that are often treated as separate. Problem one is the growing pressure to operationalize equity, diversity, and inclusion goals. And problem two is the persistent gap in breastfeeding outcomes. Canadian hospitals are increasingly expected to demonstrate measurable progress on EDI. According to the Public Health Agency of Canada, health equity is both a practice, responsive to systemic barriers, and a state in which everyone has the opportunity to achieve full health. EDI considerations are already required in federal research funding, and we can expect more direct requirements from Accreditation Canada and the Health Standards Organization in the near future. Provinces are also acting. For example, Ontario Health's EDI and anti-racism framework links hospital funding agreements and outlines explicit expectations for leadership. Hospitals are expected to embed equity into strategic plans, collect and analyze health equity-related data, and to align clinical care with equity goals. Many organizations have strong policy commitments, but implementation can feel symbolic or limited to education initiatives that feel distant from patient care. Meanwhile, breastfeeding disparities are key health disparities. The World Health Organization has called breastfeeding a human rights issue for both birthing parents and children due to its powerful role in improving child survival globally. Since the 1990s, rising breastfeeding rates have contributed to significant reductions in child mortality. Breastfeeding is associated with a reduced risk of infant death, infection, and chronic disease. It supports growth, neurodevelopment, immune function, population immunity, and food security. Breastfeeding dampens the effects of poverty in early life. But in Canada, marginalized families, including those who are young, low income, racialized, or newcomers, are consistently less likely to breastfeed. As hospitals, we have a critical role in infant feeding equity because exclusive breastfeeding during hospital stay is strongly predictive of breastfeeding duration. Enter BFI, a global quality improvement framework developed by WHO and UNICEF to protect, promote, and support breastfeeding, launched in response to predatory formula marketing, low breastfeeding rates, and global child mortality. In Canada, thanks to the social determinants of health, we don't easily see the most extreme risks of not breastfeeding, and BFI can be mischaracterized as a simple breastfeeding promotion campaign. But BFI is not aimed at changing individual behavior. It works by transforming systems, staff training, hospital policies, clinical processes. By removing barriers to breastfeeding, enabling best practices, and shielding families from commercial influence, BFI positions infant feeding not as an individual choice, but as a system-level output. How does BFI make this happen? The 10 steps to successful breastfeeding. Shown here in brief, these are detailed in the Canadian BFI Implementation Guide to describe actionable and measurable items that clinical teams can run with. Implementation of these steps has been shown to improve breastfeeding initiation, exclusivity, and duration rates. What does the evidence say? BFI implementation improves initiation and exclusivity at 3 and 6 months, even without full implementation of all 10 steps. Adherence to the 10 steps improves short and long-term breastfeeding outcomes, including after cesarean birth. And these improvements aren't just about the overall rate, but specifically who benefits. Delivering in a BFI hospital is associated with higher breastfeeding rates among low-income, racialized birthing parents. Exclusive breastfeeding during hospital stay predicts longer breastfeeding duration, particularly for mothers without post-secondary education. Implementation of BFI reduced racial disparities in breastfeeding. BFI-aligned practices in minority communities reduce breastfeeding disparities. There is also a caution found in the evidence. Inconsistent delivery of breastfeeding support, including BFI, without consideration for equity, can reflect systemic biases and reinforce inequities. The takeaway is that we can implement BFI to improve health equity, and when we lead with health equity as our goal, BFI implementation is stronger. What does that mean practically for nurse leaders working to operationalize EDI objectives? These two images are pulled from the Bright Shores EDI strategy and framework, which is aligned with Ontario Health's guidance for healthcare service providers. And you probably have a similar EDI framework developed in your community at your organization. On the left, you can see Bright Shores strategic pillars. On the right, the EDI framework. BFI most directly supports the dark blue priorities, excellence in care, and health equity, but its influence spills into the surrounding ideas as well. Here are some concrete examples of how BFI is helping Bright Shores to enact our EDI plan. We want to embed EDI into all levels of care and policy development, but what does that actually look like? BFI Step 1 requires extensive policy work involving community consultation and evaluating local needs. A specific example from our own policy development was pumping at work. We identified and we reduced structural barriers for birthing parents in the workplace by embedding the right to pump at work in our written policy. We're committed to organizational-wide staff training on EDI, but beyond general equity training, the BFI process pushes us into specifics. BFI Step 2 mandates competency-based education for all staff providing perinatal care, including cultural sensitivity, non-judgmental support, and recognition of how structural barriers shape feeding, moving equity from a high-level idea to a day-to-day clinical skill. We want to improve access to inclusive, culturally safe care. Through BFI Steps 3, 5, and 10, we implemented individualized and culturally relevant supports, including Indigenous-specific resources, multi-language materials, and use of inclusive language around gender and family structure. Our rural community is predominantly white and English-speaking, so we had to be intentional to make our breastfeeding resources for everyone. We aim to advance health equity across our service areas. BFI improves health through rising breastfeeding outcomes across populations, and its most significant impact is among those facing systemic barriers. Bright Shores metrics show that we are succeeding by achieving higher breastfeeding rates than the provincial average. What can healthcare leaders do? First, implement BFI from the executive level. Take responsibility for aligning your organization with guidance from WHO, Public Health Agency of Canada, CPS, and others to implement BFI. Maternity programs can't succeed without this support. Next, embed equity into BFI implementation. Intentionally consider the needs of marginalized families and let the BFI process be the prompt for critical reflection on systemic barriers and vulnerable populations. Address your EDI goals with BFI. Don't let EDI be a checkbox activity and turn it into a clinical action instead. Finally, leaders can advocate for systems-level BFI implementation. Despite strong evidence and advocacy, BFI remains voluntary in Canada, and nurse leaders are in a position to push for BFI to become a mandated standard and a lever for equity. Thanks for watching. I hope this presentation helps your team look at BFI not as an extra that isn't mandatory or one more thing to do, but as a tool to meet EDI objectives and a program to advance best practice in a way that helps the most vulnerable birthing families.